So welcome to the Global Health Forum for September. Thank you for all those joining today in person and online. We hope that you can hear us. If you can't hear us or if there's any issues, please just put something in the chat. It would be really great if someone could put in the chat if they can hear us. I'd like to start by acknowledging the traditional owners of the land on which we are meeting today, the Wurundjeri people of the Kulin Nation, and recognise their continuing connection to land, waters and culture. I would also like to pay my respects to their elders past, present and emerging, and Aboriginal elders of other communities who may be present in person or online today. We're hearing fine, great. My name's Maz Safe. I'm one of the paediatric emergency physicians here at the Children's and a fellow at Melbourne Children's Global Health. This may be the first forum for some of you. We aim to hold around 6 per year from speakers around campus, RCH, MCRI and University of Melbourne. And any suggestions for any topics, we'll leave our email at the end and please let us know. Before I get to today's topic, which is on disaster medicine, just let you know about what's coming up. So the Research Student Symposium is next week on the 15th and the 16th of September. And there's a few talks from our global health students. And that all the details will be in the Melbourne Children's Global Health newsletter. And later in the year, in November, there's health leaders in the Asia Pacific region visiting for a course here. And we're hoping to, in the time that they're here, it'll be a great opportunity to hear from them about and learn from their health systems in our region. So today we're joined by Dr. Peter Archer. He's a paediatric emergency physician and retrieval physician who works here at the Royal Children's Hospital. He also holds current roles with the Victoria's Field Emergency Medical Officer Program and an AUSMAT team member and a WHO Global Emergency Medical Teams mentor for Indonesia. He's been involved in many disaster team responses in the Asia Pacific. Personally, he's taught me and many members of our team in ED about the importance of teamwork and preparedness in these high pressure situations and in critical care. And so we're really excited to have him here to talk to us about capacity building for emergency medicine teams and disaster preparedness in our region. That is our email up here if anyone needs it, and I'll just pull up Peter's talk.
Okay, so I'm Peter Archer, as introduced me. I want to talk, or I was asked to talk about responding to disasters, and I think given the global health audience that we've got here, I just wanted to just re-emphasize some old lessons while trying to explain our local and national and regional responses to disaster, and we'll go through some of that. But a lot of you might remember 20 years ago now, almost, with the Asian tsunami, and a very wise man presented here in 2005, he would have presented, and I think the lessons he took out of reviewing the disaster response to the Asian tsunami, and I'm talking about Trevor Duke, he went and reviewed some of the disaster responses on behalf of WHO, and what I think Trevor found, and by all means interrupt if you're in the audience, Trevor, was that the local responders are the key people in any disaster response, and you know, even though I'm going to talk about teams going across the world and across the country, I think, you know, what we'll hopefully finish up with is, you know, the new place that we've kind of come to, which Trevor was talking about 20 years ago, was, you know, building a you know, locally sustainable, prepared disaster response, you know, when bad things happen. I think, so I've been part of the various organisations you see up there in responding to disasters for about 20 years, and slowly starting to understand why things are the way they are, and, you know, hopefully trying to improve some of the things that Trevor was talking about 20 years ago. That you know, disaster response, like many of the fields in medicine, isn't well funded. I think people, you know, don't want to invest in something that might happen when we've got so much happening in the current time. So I'll try and sort of go through a few of these things. So I kind of spend a lot of time thinking about how did we get to where we got to? Why is the system the way it is? And it's the commonest thing people ask me is, you know, I don't understand the disaster response systems locally, nationally, internationally. So I'm going to try and outline some of the recent history of Australian disaster medical assistance teams. I'm going to talk about the development of the National Critical Care and Trauma Response Centre in Darwin that houses AUSMAT. I'm going to talk about the World Health Emergency Medical Teams Initiative that really spun out of the first director, Ian Norton, and a lot of the work he did in Darwin. So we'll go through that. We'll talk about some of the AUSMAT medical responses internationally and nationally. I'll put a little plug in about Aspen, because, you know, sometimes when no one else will go to a disaster because it's too dangerous, or you can get private medical teams to go, and WHO has had to resort to that. Aspen Medical Team is a verified disaster team in Australia that's gone to some of the worst disasters. But just to re-emphasise the Children's Hospital and Victorian responses. So a lot of people don't even realise we have a disaster medical team at the Children's Hospital, and that team's deployed to Samoa and the Philippines and many other places. But also part of the local initial responders to disasters in Melbourne. Very few people actually know that we have a field emergency medical officer program, and there's about 30 field medical officers that get called around the state, and part of that initial local medical response that, you know, augments the ambulance capability and embeds the response in the bigger hospital network and local networks. I'm going to talk briefly about WHO EMT standards, because and particularly the new push on national standards. So we're trying to encourage teams to develop countries to develop their own national standards for teams. We had a lot of the teams from Southeast Asia and the Pacific say the global standards were too hard. And one of the teams I've been mentoring for half a dozen years is Indonesian Muhammadiyah team, and I'll talk to you about some of the stuff they do. The Muhammadiyah has been responding to disasters for over 100 years, and really the numbers of disasters they respond to just put anything we do to shame. So a reminder, everyone, Australia is a young country. It's a sparsely populated country. We're really a lucky country, but things are changing. And with climate change, all the geopolitical stuff that's going on, I think the angry, turbulent world we live in, I think we have to be more prepared than ever to respond to disasters. And I hope to, convince you and other people that some of this stuff on national standards we need to bring to Australia and have a good, strong, state and local responses that we can build. Actually, there we go. So the history of Australian disaster responses is really abridged. Apologies, I'm just trying to get to how we got here from where we started. So in the early 1900s, and I don't really know much about disaster response before the early 1900s, but it was really the Red Cross and the military medical teams responding in World War I and with the Spanish flu outbreak, in 1918. We had a pretty sparse history of disaster response, pretty much until, 67. We had Tasmanian bushfires. We had the Westgate Bridge collapse in Victoria. I remember my dad predicting that bridge would collapse, and 35 people died out of that, and we didn't really have an organised response. The casualty directors headed out and picked up patients and brought them in with ambulances, and out of those kind of events, we developed a national disaster organisation, which is now our Emergency Management Australia. 74, well, the 70s and 80s, we had Cyclone Tracy in Darwin, where about 70 people died. The Granville train disaster, 83 deaths and hundreds injured. And then Ash Wednesday, where there was about 70 or so people die. And some of you may remember that if you're my age, but many of you won't. Out of those events, we formed Medical Disc Plan, which is now the Field Emergency Medical Officer Program in Victoria. But still, there wasn't really organised international response. Probably one of the first successful international responses was in 1994 when we sent the military teams to Rwanda. And the Australian military went. One of my very good friends, Lindsay Bridgeford, Penny Bolt's husband, basically went with a team of military people, and they went really unprepared, by his own words, and went to a genocide where millions of people were killed and lots of bad things happened. But and Lindsay's brief was to just go and do good, and he does a great talk for our Melbourne Uni course if anyone wants to see it. But so that really was the military was really the organised overseas response, mainly because of the logistics and flying people out. In 2002 and 2004, we had the Bali bombings and military responses from David Reid, who's now the Director of Trauma at the Melbourne. He was the AUSMAT Surgical Director as well. So David and Sue Winter flew with two other doctors, I believe, and picked up 65 burnt patients from the Bali bombings and flew them back to Darwin, where they were distributed across Australia. And really, those things and the Asian tsunami were precipitants for John Howard saying we need a organised international disaster response and a national disaster response, which he put $75 million at the time, a lot of money, into Darwin, and built the National Critical Care and Trauma Response Centre where AUSMAT is housed. So AUSMAT teams sort of responded to a number of events, and the Jakarta earthquake, Ashmore Reef, which we'll touch on a bit later, the Pakistan floods. They didn't go to the Haiti earthquake, but a number of other teams did. And I put the Haiti earthquake in there because the Haiti earthquake was really a point where people around the globe said we need a better system for responding to disasters. And you know, people like Ian Norton, who was the first AUSMAT director, were just, you know, clamoring to get organisation and standards into disaster response teams globally. And you know, we'll go through that a little bit more as well. But so WHO organised this international coordination of foreign medical teams, and probably the Philippines Typhoon Haiyan was the first time where 150 teams were called from all around the world, and we had WHO and local Ministry of Health coordination of disaster teams, which was really very successful. And it's really how we've spun out the WHO EMT initiative. So EMT is emergency medical teams, and we'll go through that a bit. So that's Lindsay from Rwanda. I'll just showing a few pictures. So Lindsay went and took a team, stayed 9 months in Rwanda, and you know, basically set themselves up in a hospital that had been used, you know, by the sort of warring parties, and you know, a lot of bad things that happened in a genocide, you can imagine. And they went and set up a hospital, and then went around the communities around the hospital providing medical care, and literally just doing whatever they could with the little stuff they had. But yeah, it was really great example of you know, doing something with nothing. But I think I'll go through in a minute. But Bali bombing, so that's Sue Winter, you can see running in the military uniform. So Sue and David and two other doctors took the 65 Australians straight from the hospitals in Bali that were, you know, chaotic. They actually thought they were safer at the airport, and moving them quickly to Darwin, and you know, that really was, you know, the sort of source of where the need for an AUSMAT in Darwin came from, just the geography of Darwin being close to Southeast Asia. The Asian tsunami, a lot of Australian teams responded to the Asian tsunami. I think there's kind of different versions of what actually happened there. I think Trevor had a really quite balanced view of what happened in his presentation here. But you know, a lot of the teams went with really good intentions, but, you know, in their own words, unprepared for what they were going to face. And you know, the majority of the real work was done by the locals. And you know, out of those kind of things, you know, it became clear we needed an organised, prepared local response. And so you know, the Prime Minister and people like the current boss in the NCCTRC, Len Nataris, developed a vision that we would have an AUSMAT that would be able to respond to regional, state, national and international disasters. And that's really what they've achieved, and we'll go through some of that. But AUSMAT is the permanent response capability, you know, for Australian and sort of local, international and national disasters. So over the 15 or so years of AUSMAT, there have been multiple deployments, and particularly in the last 3 or so years, you know, starting with Ashmore Reef, the Pakistan floods, New Zealand earthquake, Solomon's dengue outbreaks and floods, the Philippines Typhoon Haiyan, various cyclones in the Pacific, the PNG earthquake. Of course, everyone will remember the Thai Caves rescue and the White Island volcano. More recently, we've had AUSMAT responding to the measles outbreak, and that was took a long time to get under control in Samoa, and then the Australian bushfires, and then multiple deployments with coronavirus and the Vanuatu cyclones. So the WHO EMT initiative really came from people like Ian Norton, you know, and the principles of we need minimum standards for foreign medical teams in sudden onset disasters, and so in clinical care and health response, good intentions aren't enough. You know, the principles and standards and quality are important even in mega disasters. You know, we shouldn't be cutting corners, and just if we can avoid it. But the other key tenet is that operational support and logistics are as important as your medical and technical skills when you're responding to disasters. And you know, as Trevor was saying, national leadership and coordination is the key to disaster response. You know, having a strong local leadership that's coordinating their own disaster response is really what every country wants, every sovereign nation, and it's what they're entitled to. And WHO has a global governance system that can support that, which we'll go through in some detail. But so there's governing principles of a response. The responses need to be timely, they need to be effective, they need to be appropriate, obviously ethical. I think one of the most important things is they need to be accountable to the local government and to the local people, and it has to be integrated with the local response. The other thing that's really important, if you're part of a team that's going internationally, you have to be self-sustainable. You can't be a burden on the country you're visiting, and that can be really hard to you know, keep up that level of self-sustaining capability. But so why do you have to be timely? It's pretty obvious with sudden onset disasters. You'll get you know, with earthquakes and cyclones and things, you'll get a trauma response that you know, you'll get basically a large number of trauma deaths early on, and then you know, head injuries, chest injuries, etc., and then trauma complications in the second phase. You'll get indirect infectious diseases, as you know, any disaster will affect your you know, your ability to manage hygiene and water and sanitation. So you know, those things can lead to infectious disease complications, and then you'll get accumulated elective care needs that people put off their care, and we're seeing that now in Victoria after COVID. So you know, the disaster teams need to be able to cater for all that, and you know, be able to supplement whatever the country wants, basically. But the other thing is, Haiti showed us there was a lot of teams that went and did stuff that they weren't really capable of doing, and you know, we had medical students and untrained technicians going over and doing all sorts of things. I think the thing that people shone a light on in particular was the very high amputation rates of some disaster teams. Some disaster teams would have up to 45% of what they dealt with. They did amputations, both upper and lower limb amputations. The work, when reviewed, was considered, you know, not appropriate, and there was, you know, and obviously they had good intentions when they were doing these things, but the world kind of said you shouldn't really be cutting off limbs if you're not credentialed to cut off limbs. And you know, there were many other things like that going on in Haiti that you know, the new WHO EMT initiative seeks to tackle and improve, and I'll go through some of that. So for a disaster team to go to another country, you really need good preparedness. You need to have all your equipment well organized and stored and ready for rapid deployment, and you need a rapid deployment capability. In Australia, AUSMAT needs the military to move overseas, and we can take a 40-ton surgical field hospital overseas in 24 hours, but we can't do that without the military. And then once we're there, we need the logistics support to be able to move that equipment.
So you actually take a hospital, a little hospital.
Yeah, I'll show you. So that's a picture of the field hospital in the Philippines, so surgical field hospital, and basically, when you're there, you have to be self-sufficient. So the team needs to be able to sleep somewhere. The team needs to be able to eat, and they need to be able to move their stuff around. They need to be able to generate their own electricity. They need to have clean water and be able to get rid of their own waste. They need to control temperature, particularly for stuff like vaccines. So the standards for the teams are pretty high, depending on the size of the team that you're going. And the advantage for the local country that's getting all these international teams offering to come in is they'll know what they're getting. And I'll go through why they'll know what they're getting in a while. But so there's a number of global standards books that you have to follow if you're part of this emergency medical teams initiative. The teams are classified depending on the size. So there's type 1 mobile teams, and I'll show Australian and other examples of the various teams. They're basically teams that can wander around to remote areas where people can't access healthcare. We did this in Fiji, and you can get into small communities and provide healthcare. That's what Fiji asked us for. There's also fixed facilities. So a type 1 fixed facility is like a tinted emergency department without a lot of stuff behind it that basically can see up to 100 patients a day, and usually isn't open at night. So most of the teams globally are only funded to that level. So it's an expensive thing to go to the next step and have an inpatient surgical facility like AUSMAT does. And there's probably a dozen or more teams around the world that meet the standards in the type 2 level. The type 3 is really a tertiary hospital in a tent. So they can provide intensive care, they can do dialysis. There's only 2 tertiary level EMTs, and they're really, if your big tertiary hospital is out of action because of an earthquake or whatever. So I'll talk about the Israeli team and the Chinese team that have achieved that level of specialization. The other thing that wasn't in the initial iteration is we have these things called specialist cells that basically the country asked for something. So they might want an anaesthetist to go and get people out of a cave, or they might want an intensive care backup, or they might want a pediatric team to come in and support them. So those things are all capable, infectious disease management, etc. So really the country can ask for specialist cells now, and WHO keeps a register of who's got what, and when there's a disaster, the local country can ask for, I want a type 1, type 2, type 3, and they'll know what they're getting when those teams apply. That's the idea of credentialing and of those teams. So that's kind of it summarized. Some of the specialist care responses have been obviously COVID, cholera, measles outbreak, Ebola, maternal and child health, and rehab is sometimes a problem, particularly after things like earthquakes. So those teams can replace damaged hospitals or damaged clinics, you know, in a disaster, and you know, just re-embed themselves to get the local health system back up and running. So currently there's over 30 EMTs that are verified, and you know, there's more than 100 that are trying to get verified, and the Muhammadiyah team is one of them. But so, you know, in terms of placement of EMTs, you know, the teams are really, as I said, there to replace a small clinic. So type 1 team would replace a damaged clinic. The type 2 team would replace a district hospital with, you know, with some surgical capability. The type 3 teams replace the big tertiary hospitals. The EMT initiative really, you know, aims to expand global and regional coordination and partnership. It sets standards. It implements capacity building and training. There's a lot of training tools and people that are shared between countries. There's also a quality assurance and classification process that each team undergoes, and then during a response, there's field quality assurance that goes on. Each team will have technical standards that they have to meet for all of those clinical things, but also operational standards, you know, in terms of how quickly they can deploy and, you know, how well organized their logistics is. Really important, you know, as I keep saying, is that the host Ministry of Health needs to run their own response. They need to know everything that's happening in their country. The disaster teams cannot invade and like we have in the past and just come and take over a country's health system, or worse still, just do stuff and then leave without handing over. So everything that's done needs to be coordinated by the Ministry of Health, or in the rare cases where the Ministry of Health is damaged or not able to sustain a response, WHO comes in and will help. And they run a emergency medical team coordination cell. So, you know, as you come into country, you get told where you're going to go and what role you're going to have. And, you know, you might think you're going as a type 1 team, and they'll say, no, we actually need you to go out and be a mobile team. And you know, you need to be flexible enough to do what they ask, really. The other thing that's really important when you're active in someone else's health system is you need to be registered. You need to, they need to know what your capabilities are. You need to provide them with daily summaries, and often multiple daily summaries, so they know what's going on with their disaster, and they can, you know, have, you know, surveillance and things of diseases that are developing in the aftermath of a disaster. They also coordinate national referrals. So, you know, you might have a neurosurgeon in the disaster area, but, you know, you might be able to move the patients, you know, in a supported way to the most appropriate facility. So, you know, the Ministry of Health will often coordinate that with WHO. And every team that goes in now has to do an exit report. So, you know, they know what you've done, and you hand over all your documentation to the local ministry when you leave. So the EMT standards, as I said, account for different sorts of teams. So if you're part of a forward assessment team, you need to go within 4 or 6 hours, and the mobile and emergency care teams, the type 1 mobile teams, need to be able to move in within 12 hours. Similarly, the fixed clinic, the type 1 clinic type rapid response team, they need to be able to leave within 12 hours. The full surgical field hospital, remarkably, can be moved within 24 hours. And it's quite something to see AUSMAT getting out the door with the help of their logistics people and the military within 24 hours. And loading everything on a C-17. The type 3 full tertiary hospitals, they're 100-ton plus teams with hundreds of people. They take a bit longer to get out the door, but the standard is they've got to be out the door and available within 2 days. Specialist care cells, obviously a bit more flexible, but depending on the needs. So these are examples of AUSMAT, the forward assessment team going to Bangladesh, with the diphtheria outbreak in Bangladesh. A small forward assessment team went and worked with the British to set up a service for diphtheria. This is us. So we went to Cyclone Winston in Fiji in 2016, and we went as a fixed type 1 team. The Minister of Health said, I don't need fixed type 1 teams. We need you to get out to the communities, and the people can't get in, the roads are shut. So we had 3 mobile teams that just went village to village on boats, on helicopters. Brett Sutton managed to get the helicopter and go around the islands. I got the big red car and drove around the main island, but yeah, it was interesting. But this is just a photo of the fixed team in Cyclone Pam in 2014 in Vanuatu, and so basically they're just running a 12-hour clinic with some capacity for retrieval and moving people as well. Probably the response we're most proud of in Australia, and obviously a disaster for the Philippines, was Typhoon Haiyan, and the Philippines are really very good at managing cyclones. It's another cyclone, big deal. So this was different. This was possibly one of the 2 strongest cyclones to go through the Philippines and the world in 2016, 2013, sorry, and 6,000 people were killed, 28,000 people injured. The president of the Philippines called it a state of calamity, and he asked for teams from all over the world to come. So 150 teams all descended into Tacloban, into this area that had a 5-meter wave go through, and the typhoon as well. This was our reason for being. That is EVRMC Hospital, and that hospital's been knocked out. The roof and the top level's been taken off, and the wave's gone through the surgical facility. So they were still running that hospital through the 2nd floor. So it's remarkable. But AUSMAT was asked to take a surgical field hospital, and we set up their surgical area near the airport. But so they would get the patients, and other disaster teams, the smaller disaster teams, would get patients that needed surgery, and then they'd move them to the AUSMAT field hospital. So the AUSMAT team was there for 23 days. We saw 2,700 patients. We did 238 operations, 90 major operations. You might notice some of the children's hospital people there. We were a decent part of the pediatric response. Yeah, I'll just show you some of the things. So we flew over on a C-17 and basically had a surgical facility set up by the Alpha team, the first team that flew in, who did a remarkable job. They actually did most of the work, I think. This is an example of what happens in Darwin. You meet at the warehouse, you get given a bag, you're allowed to have 3 kilos of your own stuff, and the rest is stuff to keep you safe, and your uniforms, and then you go on a C-17 with your kit, and and then you arrive to your ready-made free field hospital, yeah, basically the hospital had 60 beds and 2 surgical tables, and yeah, basically could do most things. So we had the ED set up in a tent, and unfortunately for emergency physicians, our tent wasn't air conditioned, but the wards were. So I've never spent so much time reviewing ward patients in my life. But, that was my way of cooling down. We had a lot of pharmacy and other supplies that you know, got replenished when we needed. Our accommodation, you know, we'd have 20 people in that tent when we first arrived, and then managed to spread out a little bit hot and uncomfortable. And we were at an airport, so it was pretty noisy 24 hours a day. But very good. The one thing that we had even after the typhoon was every day we'd get a meter of rain coming in, and you know, would flood everything, so we'd have to clean it up and start again. But it was almost predictable, the timing, which is interesting. The key thing to a disaster team is not the clinicians, it's the logisticians. And in Darwin, they have done a remarkable job with the local firemen, and I didn't even realize that most firemen have a trade, so we had electricians and chippies, and you know, people that did refrigeration and water, and you know, we had everything that we needed basically. You know, we needed a coffin, child died, they built the coffin. You know, we needed crutches, they build the crutches. You know, so remarkable what good logistics people can do for you. But and the other thing, they helped you know, fix things at the local hospital so they could get up and running fairly quickly. So this is us. You can't just go into someone else's country when you don't speak their language. And you know, what we did really well, and you know, all the disaster teams should do, is, you know, we got local people assisting us. So we had 14 Filipino nurses that really did a lot of the translation, and acclimatized us as much as the patients to the local conditions, and you know, how do we do things here kind of questions. But this is a helicopter crash. So we had a helicopter crash towards the end of our stay, and you know, the local emergency boss came and helped with some of the surgeons. So you know, it was really a great collaboration with the local Filipinos, which is what you have to have. In terms of
Sitting on, we've got 2 minutes left. I just want to make sure, are we able to hear a bit about the mentoring of Indonesia?
Yeah, sorry. Yep.
No, you're fine. I just want to make sure we don't miss out on that.
Just put a little plug for the Type 3 teams. That some of the specialist cells, and you know, obviously the cave diver. Brief plug for Aspen, who went to West Africa for Ebola, and Mosul, as you know, places that AUSMAT wasn't allowed to go. Yeah. Just a reminder, with the Ashmore Reef explosion, that AUSMAT responds to national disasters as well, and you know, remarkable story. 44 people burnt and moved within 24 hours to all other states. Just some of the FEMO program things, the Kerrang train crash, the Black Saturday deployments, and we got VMATs out to some of those. Thunderstorm Asthma, the bushfires in 2020, and you know, obviously the multiple COVID responses. So we're pretty busy. Claire Wilkin went with me to Amesbury recently, you'll remember. So in 2020, WHO was really starting to get on board with some of the stuff Trevor was talking about in 2004. And that recognition that most of the work is done by the affected country medical team. So we've had a focus on building emergency medical teams in each country. And Thailand and Indonesia in particular have embraced that concept. Indonesia has now got hundreds of disaster teams, Indonesia is a massive population and really a disaster supermarket in terms of, bad things happen in that area of the world, volcanoes, earthquakes, floods, and tsunamis, obviously. But one of my roles with WHO is to mentor the Muhammadiyah emergency medical team, and I didn't know much about Muhammadiyah, but Muhammadiyah is probably the most active disaster team in the world. They respond to 20 to nearly 50 relief and disaster responses a year, and they've been all over the globe to respond to international teams, even though they're not actually registered yet. They certainly deserve to be, are about to be registered when COVID came. And their problem is, and I'm sure a lot of the developing country, and I don't think we should call Indonesia a developing country anymore, but they kind of use their stuff before they have time to show to get verification. So it's a real dilemma, because we've had them ready a few times to get verified, and then the disaster comes and they've just got to go, and it all gets cancelled, and they use all their stuff. They are so generous. They went to Turkey for the recent earthquake. Australia didn't go to Turkey. We should have gone to Turkey, but they took all their stuff. They gave everything to Turkey. So now we're starting again. That's that map is some of their disaster responses in recent times. But remarkable what they do. Muhammadiyah itself is an organization of 35 million people, and they have basically when they have an annual meeting, they get 1 million people to come, and you just can't imagine the size of what they do. They have 457 hospitals, 176 universities and colleges, and when they need money, they fundraise. So, and that's one of the challenges when you're working with them to try and get them on a World Health standard, is they have to fundraise and get things. So, and they make everything locally in Indonesia. They don't import stuff. So there's certainly challenges when you're trying to meet global standards. And one of the things that a lot of the ASEAN countries argue is that the WHO standards aren't right for ASEAN. And and so some of that national stuff, you should be able to dictate your own standards in your own country. And not every small country is going to be able to afford a type 3 facility when you're struggling to meet the daily needs. Any questions on Muhammadiyah? Because we could talk a lot. VMAT is another example in the Pacific, and there's developing capability in other Pacific countries. And when there's a disaster in Tonga or Samoa, the local hospital just responds. And if they need help, then they'll call Fiji, they'll call Indonesia, they'll call us, and they're pretty good about that. But the ASEAN countries are really they have this disaster center called the AHA Center, and they really like to lean on their neighbours more than they do on Western countries, and that's completely fair. They're culturally much more appropriate. They speak the same language, and so yeah, I think that's some of the rationale for why the system is the way it is. So I presume I haven't got much time, but really wanted to just re-emphasize that for effective disaster response, you need the PPR, and so prevention, preparedness, response, recovery, really well set up. You need understanding of command and control, your own team safety, communication, assessment, triage, treatment, and transfer. They're the basics of disaster medicine. But really, the lessons that I've learned over 20 years is that we really need well-prepared, rapid local responses that are integrated with good health systems, and that's what we should spend our money on. We need pre-hospital medical team capability, like the VMATs, like the FEMOs, if there's prolonged scene times. Otherwise, ambulance does most of the work and does it really well. And the best thing you can do is have rapid transport to hospitals if you can. So what we try and do in Victoria is when we have disaster victims, we try and distribute those, within the limits of the transport times. So we're not getting all the burden on one hospital, one health service. The other thing that's really important to consider, and we saw this particularly with COVID, was we need a scalable response. So if one hospital is challenged, we need to be able to bring in resources from elsewhere. And in COVID, we moved people from different networks to go and help Mildura and Shepparton and areas that were challenged. And we would move the patients out to some of the bigger hospitals, with the COVID hubs when required. So we really need strong local, national, and regional capabilities, and all that's bubbling away in the background without you knowing. Global standards mean that countries receiving assistance can know that the teams are fit for purpose and know exactly what they're getting, and that they're not getting a burden team. But future work, we're doing some work on climate change at the university. We're having a heat health workshop in 2023. Probably the big thing on the national landmark is we're getting a national CDC. I don't know if that's a secret or not, but and the disaster teams will be integrated under the banner of the CDC. Personally, I want to do a review of the medical assistance teams and look at the national approach to emergency medical teams and maybe compare it to what happens internationally, and look at standards, kits, logistics, training, and really importantly, in Victoria, we need access to transport if we're going to have an effective pre-hospital service coming out from the hospitals. That's it. Any questions?
I just wanted to ask Peter, what would your idealistic, what would be the ideal situation that you've worked with Muhammadiyah as far as skilling up local disaster teams or local emergency medicine teams? Like, what do you think they need? More kind of mentorship or?
Yeah, I think each country needs to be able to decide, what level of care fits in best with their health system, and that's really challenging for me as somebody coming in who doesn't really understand the Indonesian health system, to come and say you have to get to this global standard. And half of my time when I'm there is spent with people saying, but we don't need that. When we go to a disaster in Indonesia or in Malaysia, or then we stay with people. They give us food and water. They so some of the standards that are there as global standards, so we're not a burden. Those things are understood locally amongst friendly countries and pre-done agreements like the AHA system for ASEAN countries, they just work and they don't need all of the level of stuff. So, this push, and I had the pleasure of being part of that, initial national accreditation meetings and saying, the country needs to be able to decide what fits in with their standards. There's no point, bringing, a Chinese or a Russian team or whatever they can't speak the language, has different medicine, and, it doesn't fit. They do stuff and then they leave, and it's not integrated with the health system. So, and Australia's just the same. Like, there's some countries we will go and we will offend people and we will cause problems, and we have, and we've gone with really good intentions, but the one thing I've learned is that everything you do has to be integrated, and I spend a lot of time asking local clinicians or ringing the local director of emergency or whatever and saying, how do you do things here? Well, the GPs, we're out, in the middle of nowhere. How do we manage this here? And the practices are very different, but people still, that's their health system, that's how people manage, and we have to respect with that. Yep.
Yeah, so finding that balance between sending an outside team for that really acute period, but also integrating, deploying the local team, integrating the local health system.
And that's really hard to get. Like, I did the verification of the Chinese type 3 team, and one of the sticking points was they said, why would we practice like anyone else? We're the best in the world. So, I'm sure there's plenty of, I'm sure Australians think like that too. We just have to understand we're guests. I always think of myself as a guest in someone else's house.
Maybe a follow-up question from that, Peter. So I gather that a key, and you spoke about it earlier, key point of EMT, international EMTs is coordination from the ministry, the local ministry. If you've got a country that's got political unrest, or the government regime is in contrast to the international, I guess, what we would feel would be appropriate, how do we sort of navigate, or how do you sort of navigate that space?
So, I guess Mosul is an example of, no man's land. Like, none of the teams, not even MSF, wanted to go into Mosul. WHO sort of somehow negotiated with Aspen to go in there. Kat Franklin, I don't know if you're online, Kat, but Kat went to Mosul and went behind, the lines, and enormous risk. But most rational teams wouldn't do that. but you have to pay sometimes for people to take risks. A national team like Australia is not going to put their staff at those kind of risks. Ebola's the same. Ebola in the Congo, the local Congolese were burning down, Ebola treatment centers. Their view, which I think is quite a rational view, is we don't want you to come in and just treat Ebola. We want you to treat everything. And why are you not looking after our people with TB and malaria, and you're only interested in Ebola because you're scared of Ebola? And they're dead right. We should be doing the whole lot. Those in certain countries, because of war or because of political instability, where the national system doesn't work, WHO needs to find a way to deal with that. Sometimes they do, and sometimes they haven't. And some of the African disasters of genocides, etc., they're probably too hard. They're probably too hard for most people. But yeah. Okay.
Probably all we have time for. Thank you so much, Peter.